3, 2, 1.
Good evening. I apologize first for very poor state of my voice. So I can't talk much today, and you have to be extra careful to listen to me. National Allergy Asthma Bronchitis Institute is engaged in training, research, and clinic since its inception in 2008. Teaching has always been an integral part. Our previous modules on obstructive airway disease, tuberculosis, and diffuse parenchymal lung disease have been extremely popular. This time, we have turned online. Our previous two classes have reported very good feedback, and our motto is to do it better every time. But this is not a webinar. This is a class, Novi Pulmonology Master Class. So welcome you back to our Novi Pulmonology Master Class. Here we choose the topic according to their clinical importance, the basic concept, and the confusion or controversy that needs to be cleared. Today, I am not getting it. It's not moving away. Hello?
Click on the screen.
Yes. Today, our topic is approach to diffuse parenchymal lung diseases. Faculty Ongsuman Mukhopadhyay and Devvani Vishwas, the two next generation pulmonologists and experts, one from Sagat Datta Medical College and another one from Amri chain of hospitals in Kolkata. Now, before Ongsuman talks on the different aspects of idiopathic pulmonary fibrosis and chronic fibrosing ILD, and after that, Devvani would speak on hypersensitivity pneumonitis, the enigma, and the CTD-ILD group of diseases. I start with an introduction because again, this is a classroom, so everybody must be catered for. We start with the very basic. Some of you may find superfluous, but this is Novi Pulmonology Masterclass. So, why should we discuss DPLD? Because DPLD is not uncommon. If you are not getting them, you are missing them. This is just to show you the prevalence of ILDs as it is unfolding in India. I'll show you particularly this one at the middle. This is the India ILD registry done at the behest of Indian Chest Society and also National College of Chest Physicians. We all were part of this. And you can see the different diseases according to presentation. So IPF, hypersensitive pneumonitis, CTD-ILD, sarcoidosis, and other ILDs. I'll point one peculiar thing here. Just see HP percentage in this India ILD registry. Huge, 47%. Previous reports from our part, DPLD East registry, see, it was nearly 11%. And look here, the North India PGI registry also gives HP the same incidence. And we thought IPF was the maximum in prevalence or incidence. Here we gave them 38%, PGI Chandigarh reports 25%, but All India registry claims it is near 14% only. That means the full spectrum of ILD is unfolding before us, and there are distinct change in different countries. Taking all together, hypersensitivity pneumonitis is really very much underdiagnosed still in our country and in the globe. So ILD India registry has made us conscious about the enormous incidence of hypersensitivity pneumonitis due to various reasons. You know, there are pigeon excreta, then there are these air coolers altogether. I remember when I look back in the 60s, ILD itself was difficult to think of as a distinct disease entity. So 60s went just to establish that ILD is a different disease compared to those days tuberculosis and bilateral extensive bronchiectasis. Then in the 70s we understood, mind it, CT scan was not there, only clinical and chest X-ray, is that ILD is just an anatomical diagnosis. That means you diagnose pleural effusion, that is not the end. It is the beginning of the journey. You diagnose pneumonia, you diagnose obstructive airway disease. Similarly, you diagnose ILD means it is just an anatomical diagnosis, involvement of the interstitium as we understood those days. And then you have to go for the final diagnosis, what caused these ILDs. So anatomical diagnosis done, we have to look for etiological diagnosis. Then came the 80s, mind it. In the 80s came the CT scan. And there is unimaginable improvement in imaging, as also molecular biology and sampling of lung, bronchoscopy, bronchial lavage, transbronchial biopsy, all unfolded after the 80s. And now we knew the huge spectrum of interstitial lung diseases. Am I audible? Yes?
Yes.
Yes.
Okay. Please give me feedback. Okay.
Okay, sir.
So, Lupin Carrington tried to classify them in 1969, but that did not percolate to the general medical fraternity at that point of time. Rather, it was changing later after the 80s. There was a change in nomenclature. We thought it was primarily interstitium, we called it ILD. Then we knew the adjacent alveoli and pulmonary vasculature are also part of the involvement. So we recoined the term diffuse parenchymal lung disease. Then we thought a particular type which was characterized radiologically and histologically was this fibrogenic foci in usual interstitial pneumonia. So we are changing the terminology and the understanding is not yet complete. Just approach to DPLD. So whenever we get a patient, we'll show how do we get them. But once you diagnose that this is DPLD, the job is only the beginning. So this is the most simplified classification. So DPLD of known cause or association, there are some we can go for them. Rheumatological, say rheumatoid arthritis, progressive systemic sclerosis, vasculitis, environmental, the very big chunk of hypersensitive pneumonitis, drugs. So we know them, this is known. Then there are the granulomatous diseases. Actually, granuloma is something, a histological term. But still, when you get granuloma, you can think of some diseases, sarcoidosis, Chukstras. That time it was named as Wegener, the name has changed. Lymphomatoid granulomatosis. but still we know something about them. So this is also probably known. The other forms of interstitial pneumonia, which exactly cannot be watertight, compartmented, wise classified. The group known as say lymphocytic interstitial pneumonia, practically it has been taken off. Then eosinophilic pneumonia, LAM. So we know something about them. So these are known. Only when you take out the known, what remains is the big chunk of unknown. Where is the cursor? I'm not getting it. Yes. Big chunk of unknown is the idiopathic interstitial pneumonia. This is unknown. And science and mankind always goes after the unknown. So now we start the journey to this unknown part. So idiopathic interstitial pneumonia again is a big chunk. If we take out the others, it will be easy. At one size, one is enough, idiopathic pulmonary fibrosis. The others are there are different groups, but again, we probably know something about them. For example, say discomative interstitial pneumonia and respiratory bronchiolitis interstitial lung disease, practically smoking-related diseases, and as you know the etiologies, they should be taken out from here. They should not be part of idiopathic interstitial pneumonia. Cryptogenic organizing pneumonia is a different picture. Starts like atypical pneumonia, may be progressive, may respond to steroids, and there are radiological signs, not necessarily present every time. The reversal sign out. It is not part of the picture of idiopathic pulmonary fibrosis. Acute interstitial pneumonia is a devastating illness. We have seen young lady of no disease, bolt from the blue, 10. And so, acute interstitial pneumonia is a devastating disease. We can take them out. Lymphocytic interstitial pneumonia practically is not part of the classification now because it is usually secondary, maybe seen in lymphoproliferative diseases, HIV, Sjogren syndrome. So if we take them out, these remains. Idiopathic pulmonary fibrosis, why should be concerned? Because the huge morbidity and mortality. The mortality from idiopathic pulmonary fibrosis is more than some of the common known cancers. And the close mimic, but prognosis-wise and treatment responsive-wise better is the non-specific interstitial pneumonia. So this is our background mindset in approach to diffuse parenchymal lung disease. The first, some sort of global, actually they thought America and Europe formed the globe that days, 2002, the classification of idiopathic interstitial pneumonia, not IPF, IIP. And then they tried to correlate the clinical part with the pathologic part because a lot of improvement in imaging and molecular biology pathology had been done by this time. 2011, the state went for IPF, not the total picture of IIP, only IPF, idiopathic pulmonary fibrosis, guidelines for diagnosis and management. Then in 13, they looked back and updated the classification of IIP, idiopathic interstitial pneumonia. They categorized it like this: the chronic fibrosis, that is IPF, or idiopathic non-specific interstitial pneumonia. Forget about the others, the acute we have discussed, acute interstitial pneumonia, subacute, cryptogenic organism pneumonia or cough. Smoking related should be taken out from this group, and it is being taken out. So I'll show you one practical classification when you are approaching the patient. A big group is exposure related. Again, it may be cigarette smoke, it may be hypersensitive pneumonitis. A big chunk is autoimmune related. A small is genetic. Take this all out. What remains is here, idiopathic. Yes, idiopathic is idiopathic interstitial pneumonia, And the prototype is idiopathic pulmonary fibrosis. So this is the approach. ক্লাসে আছি তাড়াতাড়ি বলো ক্লাসে আছি তাড়াতাড়ি বলো ভেবে দেখছি 9:30 ফোন করো So this approach is known to everybody. Symptoms, they come with chest x-ray. Never forget the spirometry. It is very good for monitoring, not for diagnosis. And ultimately HRCT chest. Symptoms are related to anatomical involvement as the lung is drying up, more progressive shortness of breath. Clinical picture, it is important by absence of some, for say hemoptysis. Again, it is very unlikely that a patient of idiopathic pulmonary fibrosis will come with hemoptysis. Probably it is something else. Past medical history, a complete addiction, occupational and domestic environmental history, clinical examination. No B class cannot overlook chest x-ray. Nowadays, whenever we see a case of ILD, we immediately search for the CT scan. Believe me, chest x-ray is still to give something. So decrease lung volume there, that is the most important part. But what is important? The understanding that chest x-ray is non-specific. Yes, we do agree. But a rare patient with ILD will present with a normal chest radiograph. That is actually a myth. And if it looks normal in a case of ILD, always go for previous chest x-rays. So chest x-ray can give you clue, provided you have all this awareness, that is the suspicion about the disease, acquaintance with the disease, patient identification that this x-ray belongs to this patient, and pattern identification, both in chest x-ray and in CT scan. Just one chest x-ray for you. I've just written it here, sarcoidosis, but you can see well, looks a female, no lung volume contraction, diffuse parenchymal abnormality. A pulmonology expert knows very well, sarcoidosis does not only present with bilateral lymphadenopathy. This is one of the not so uncommon presentations of sarcoidosis. Chest x-ray gives you clue about all this: onset, progression, chronicity, stability, but poor correlation with the activity and prognosis. The importance of previous chest x-rays cannot be overemphasized. And after chest x-ray, naturally, I can stop without having one on this. So it is now, the diagnostic criteria is by CT, high resolution CT chest. And again, so here, so these subpleural honeycombing stacks of reticulation with traction bronchiectasis is IPF, idiopathic pulmonary fibrosis. Anything here without the honeycombing makes it a probable UIP. So subpleural basal honeycombing with traction bronchiectasis is classical usual interstitial pneumonia, UIP, not necessarily IPF, UIP. Anything lacking this honeycombing, but still it is subpleural, traction bronchiectasis, reticulation, this is probable UIP. And anything lacking the subpleural part here is anything else. It can be non-specific interstitial pneumonia, idiopathic, or secondary to some other diseases. And usual interstitial pneumonia is just a radiologic diagnosis. Commonly IPF, it can happen even in rheumatoid arthritis. It can happen even in cases of hypersensitivity pneumonitis. So this is the background we discussed about approach to diffuse parenchymal lung diseases. I'll stop here. Dr. Angsuman Mukhopadhyay, consultant pulmonology and expert, Amri Group of Hospitals will take over. Okay, Ongsu, please.
A very good day to all of you. And today, in our session on the masterclass for ILDs, I will be focusing on the understanding of fibrosing ILDs to whatever justice I can do to this topic in the coming 20-25 minutes. So let's shoot off to the first background that we have on the diagnosis of the classical fibrosing ILD, that is idiopathic pulmonary fibrosis. And this was way back in 1999-2000, when the diagnosis of idiopathic pulmonary fibrosis was a mixed bag of clinical, physiological, and biopsy and radiological picture all taken together. And you had major and minor criteria for the diagnosis of idiopathic pulmonary fibrosis. And that's how we learned the first tricks of the trade in the diagnosis of interstitial pulmonary fibrosis. However, there was a paradigm shift in 2011 when this article was published in the Blue Journal. And the whole paradigm shifted from diagnosing on the basis of clinics, radiology, physiology, to a diagnosis based principally on radiological parameters. And the high resolution CT scan became one of the principal weapons in diagnosing idiopathic pulmonary fibrosis and or differentiating IPF from all other idiopathic interstitial pneumonias, as well as other interstitial pneumonias of known and unknown causes. And the HRCT findings were classified into three groups of a classical UIP pattern, a possible UIP pattern, and a pattern which was inconsistent with UIP. Now, the whole idea behind this classification was because other than the classical UIP pattern, which matched clinically and pathologically with the diagnosis of interstitial pulmonary fibrosis, idiopathic pulmonary fibrosis, there were other patterns on the CT scan which we saw, and those patterns also were associated with the histopathological diagnosis of idiopathic pulmonary fibrosis. And that is where the conundrum all started. So, because these other patterns could also be associated with other diseases, so we tried to increase and improve our skills into diagnosing idiopathic pulmonary fibrosis, which was a classical example of a fibrosing ILD, with the help of the HRCT scan alone if possible. And the criteria were reasonably clearly laid out, and for findings of radiological findings of subpleural basal predominant findings, reticular abnormalities, honeycombing with or without traction bronchiectasis, and absence of features listed as inconsistent with UIP were good enough for a confident diagnosis of idiopathic pulmonary fibrosis. And in the lower panel, I have shown you two CT scans, which I think is a hallmark of a typical case of idiopathic pulmonary fibrosis. However, medical thinking keeps on changing, and things change a little bit again. And a new IPF guideline came up in 2018. And there were two new categories which were created. The probable UIP category, which was a new HRCT category of subpleural basal predominant findings, but no honeycombing, but there was peripheral traction bronchiectasis. This was a highly predictive of IPF histology, where there is a clinical suspicion of IPF. And the other was inconsistent with UIP group was replaced with two categories of indeterminate for UIP and an alternative diagnosis. Alternative diagnosis, as you all know, are findings which are associated with other known causes of diffuse parenchymal lung disease. And there was another group which was indeterminate for UIP. Many patterns which were previously considered inconsistent with UIP were occasionally observed in atypical UIP cases, and that was the reason why it was an indeterminate for UIP category was put in. Now let us look at these categories a little clearly. First is the UIP category, which did not change from the 2011 classification, and it was of subpleural findings, as you see in the panels here, basal predominant, distribution in a heterogeneous pattern, and there was classical honeycombing with or without peripheral traction bronchiectasis. So all the classical hallmarks of IPF pattern are seen in this panels that is shown on your right. Then came the group of probable UIP where the honeycombing was lost. You don't find any high honeycombing in these patterns. There's only a basal reticulation with a traction bronchiectasis. So you may have a mild ground glass opacity, but this ground glass opacity should not exceed the amount of reticulation. Then you have the other group, which is indeterminate for UIP. Here, the traction bronchiectasis is also done there, but it is a subpleural basal predominant. There's very subtle reticulation that you see on these panels, and you may have some ground glass opacities. So the CT features and our distribution of lung fibrosis do not suggest a specific etiology, but could be due to UIP, which needs to be confirmed on a histopathology. And there are findings which suggest an alternative diagnosis, like the panel on the right, extensive ground glass opacities, much more than any reticulation that may have been there in the background, is unclassical, profusion of micronodules, presence of bilateral hilar lymphadenopathy, peribronchovascular findings are all features of an alternative diagnosis. So when you have cysts, marked mosaic attenuation, predominant GGOs, micronodules, nodules, definite consolidation, you start thinking of other disease patterns. And if you have pleural plaques, dilated esophagus is a finding that you find in scleroderma, dilated diavicular erosions present in rheumatoid arthritis are findings which are associated classically with known causes of idiopathic fibrosing ILDs. So when do you think is a histopathology necessary? So the decision to use histology requires a multidisciplinary discussion, first of all, including the patient, because the procedure carries a risk to the patient. And when you have a newly detected ILD of an unknown cause, and the HRCT pattern is typical of usual interstitial pneumonia, which is again a hallmark of idiopathic pulmonary fibrosis, then you do not need a histopathology, nor do you need a BAL, nor do you need any other form of surgical lung biopsy. But if the HRCT pattern is probable UIP, indeterminate for UIP, or it suggests an alternative diagnosis, then you will need a histopathology supported by a BAL if possible. But we have to remember that the histopathology to be done, we need a good surgical sample, and a surgical lung biopsy is limited by the patient's physiological status. If the patient's physiological status is poor, then a surgical lung biopsy carries a high risk. I will not go into the histopathologic patterns and features because as clinicians, we are at the mercy of, you can say, pathologists to understand what this slides show. But the histopathology has also been divided as per the radiological criteria into UIP, probable UIP, indeterminate for UIP, and alternative diagnosis. And this is a large topic on its own. But again, since the understanding of 2011, where the diagnostic criteria was shifted to the radiological patterns, it was also realized that the clinical behavior of the disease also determines the prognosis and the outcomes. And the clinical behavior in chronic fibrosing ILDs was much different from those who presented acutely, like patients with cryptogenic organism pneumonia or patients with disformative interstitial pneumonia. So the prognosis was different, and the chronic fibrosing ILDs had a nature of progression which was on its own, which was different from all other idiopathic interstitial pneumonias. So a classification of the ILDs was done based on the clinical behavior and the presentations as well into chronic fibrosing ILDs, smoking-related ILDs, and acute or subacute interstitial pneumonias. Interestingly, if you go into this classification on the basis of the disease behavior, you are left with two clear groups. One is the reversible group, or the marked with solid red arrows, and the other is the box here, the dotted box here, which is the group progressive lung diseases, progressive fibrosing lung diseases. And these clinical disease behavior is distinct from the reversible disease processes. And the progressive irreversible diseases may have a sequelae where they might stabilize with treatment or naturally, or they might go into a slowly progressive lung function decline. So the concept of idiopathic pulmonary fibrosis as a hallmark of a progressing fibrosing ILD emerged, and also the fact that progressing progressive fibrosing ILDs was probably a little different from the other forms of ILDs. So when you had a progressive fibrosing ILDs, you started thinking of diseases of UIP without honeycombing, possible UIP, NSIP. It was inconsistent with UIP, but histologically UIP, IPF, chronic hypersensitivity pneumonitis, and end-stage lung disease of any cause would appear to have a chronic and progressing decline in lung function and fibrosis. The non-fibrosing ones were HP, DIP, sarcoidosis, cystic lung diseases, pulmonary edema, lymphangitis, AIP, and the rest. And the fibrosing ILDs had some typical findings. They were characterized by presence. It is not necessary that all these findings will be present, but honeycombing, traction bronchiectasis, distortion of architecture, and intralobular septal interstitial thickening were findings associated with fibrosing ILDs. And if you had all of them at one go, it would more likely going to be UIP. And when I say UIP, you remember three S's, 3S. One is subpleural, the second is shared walls, and the third is several layers of stacked cysts. So subpleural, several layers of stacked cysts classically defines UIP, with or without traction bronchiectasis. But mind you, honeycombing has certain mimics. The principal mimics are bronchiectasis. Emphysema can sometimes mimic, but you have to differentiate between the honeycomb cyst and the emphysematous and emphysematous cysts, as you see on these panels. Cystic lung diseases have to be differentiated from honeycombing. Traction bronchiectasis, just do not mistake traction bronchiectasis for peripheral cysts. Paraseptal emphysematous cysts are also sometimes confused as honeycombing, layers of honeycombing. Non-specific cysts, as in cystic lung diseases. And sometimes the sagittal images help in localizing and rationalizing the nature of the peripheral cystic lesions that we see in the interstitial lung diseases. And sometimes you have no honeycombing but only reticulation. So these can also be forms of idiopathic interstitial pneumonias, and these probably are the ones where we should go more aggressively for biopsies. The presence of honeycombing allows us to confidently make a diagnosis of a usual interstitial pneumonia pattern. So when you have a usual interstitial pneumonia pattern, what are the criteria? It's a reticular abnormality, it's honeycombing with or without traction bronchiectasis, it is subpleural basal predominance, absence of other findings like ground glass and nodules. And when you have these findings, the classical UIP pattern, the pathologic pattern is most likely going to be UIP. However, only 16 out of 75 patients in this study, which was published in Radiology in 2014, only 16 out of 75 patients who were pathologically UIP showed a typical UIP pattern on radiology. So, CT is highly specific for the diagnosis of UIP IPF, but it is not a very sensitive tool. And that is why we still need lung biopsies to differentiate the IPF from other diseases, especially when we do not have a typical UIP pattern. And as I told you, when you have a typical UIP pattern, I have shown you the images, but then you start taking away elements out of the typical UIP pattern. You take away the honeycombing from the typical UIP pattern, and you see on your right-hand panel what you have. You have reticular abnormality at the peripheries. You have some amount of traction bronchiectasis, if you can see my cursor here. You have subpleural and basal predominance. You have absence of other findings. There's not much of ground glass. There's no nodules. And it has got a heterogeneous appearance. This CT had some upper lobe involvement. And it was sometimes at places it was non-segmental, and these findings were crossing the fissures. So these are patterns which are not typical of a UIP disease, but a possible UIP pattern. Now you take away another finding out of this classical UIP pattern. You take away the traction bronchiectasis and the honeycombing out of a typical UIP pattern. And what are you left with? You're left with a reticulation in the peripheries of subpleural basal predominance and the absence of other findings. And what could this be due to? It could be due to UIP, but it could also be due to NSIP. So these are situations where we probably would need biopsies. And sometimes follow-up helps. You see these patterns. In 2002, it was an NSIP pattern. But in 2012, you see, it has emerged into a frank UIP pattern. This is a possible NSIP pattern, UIP NSIP pattern, initially in 2004, and in 2006, with treatment, it has resolved. So this suggests an NSIP pattern. Sometimes we do not have any change over the years, and here it becomes very difficult to determine. The patient's physiological progress is the most important marker. And sometimes we have cases like this. This is a 57-year-old man, no connective tissue diseases, non-smoker. This CT was labeled as a possible UIP on our ILD meeting. He had a UIP pattern on lung biopsy, and he was diagnosed as an IPF. So there will always some patients in whom the CT will not be able to give you a very clear idea as to the diagnosis, and sometimes you will need to do lung biopsies to get the picture, and it is impossible to differentiate and sometimes impossible. So now again, you take away some elements of the classical UIP pattern. You take away the subpleural distribution, you take away the absence of micronodules, you are left with reticular abnormalities, as in the peripheries you see here. You have some honeycombing, but some traction bronchiectasis as well in the peripheries. And you add some ground glass opacity. Here in the right-hand panel, you see a significant ground glass opacity. There's some central lobular nodules, and you have lobular areas of air trapping. So what could this be due to? This could be due to chronic hypersensitivity pneumonitis. This is a subacute hypersensitivity pneumonitis progressing to a chronic HB pattern. But the problem with CT scans is very little concordance between what the radiologists do. They have very little. This is a slide I have taken out of my friend Bhavin Venkaria's presentation. So this is the radiologists hardly concur, and the degree of concordance is very low in patients in all types of radiology consultants, fellows, radiologists, thoracic radiologists, general radiologists, everybody taken together. So now that we have a clear idea of what the UIP pattern is and what happens when we take away elements out of the UIP pattern, we understand that there is also a group of the progressive pulmonary fibrosis pattern, where you have progressive pulmonary fibrosis, you have worsening respiratory symptoms, there is declining lung functions, there is resistance to immunomodulatory therapies, and obviously these patients have a very high mortality. And how would you define progression? There would be an increase in fibrosis as evident in the CT thorax, worsening DLCO, worsening symptoms, worsening health-related quality of life. But there is no consensus as to how disease progression should be defined, as to what exactly is the quantification of the fibrosis, what exactly are the values of DLCO which are important, and what exactly is the St. George's questionnaire scores which are important to define progression. So these have not been very clearly defined. But in a retrospective analysis of the impulses in the Tomorrow trials and also in the Ascent trials, they took an absolute FVC decline of 10 to 15%, and who had a high risk of mortality. So those were the persons who probably were the ones who were progressing rapidly. So a worsening lung function, more than 10% of relative decline in FVC, or a 5 to 10% decline with decline in lung function and also worsening respiratory symptoms, or a marginal decline in lung function but evidence of increased fibrosis on the CT, despite treatment with unapproved medications used in clinical practice, would lead to a definition of a progressing fibrosing ILD. So more than 10% decline in FVC, or the 5 to 10% decline with worsening pulmonary function parameters or worsening radiological parameters would define the progression of ILD. But why are we interested in progressing fibrosing ILDs? Because progressive fibrosing ILDs have been found to have shared genetic predilections. They have sometimes similar links between short telomere length and mortality. And there's a link between the alveolar epithelial cell injury and pulmonary function decline. So IPF is somehow linked to SSc-ILD, CHP, and RA-ILD. So the progressive fibrosing phenotypes would rather now need more attention. And the initial, and this is an interesting paper which was published last year in the Current Medical Research. It showed the various types of progressive fibrosing ILDs and how they presented. And the initial symptoms of ILD to the diagnosis of ILD was a mean period of 12.7 months, almost 13 months, 15 to 13 months to detect progression of ILDs. And the development of progressing fibrosing ILDs was also associated with an increased risk of death between 3 to 4 years. Physicians estimate that 18 to 32%, almost a third of the patients diagnosed with non-IPF ILDs, develop a progressive fibrosing phenotype. And these are the patients where treatment is a challenge, because 25 to 50% of the patients with progressive fibrosing ILDs do not receive any drug treatment because there are no strong clinical trials, and there's an unmet need for effective and well-tolerated treatment to address these patients with progressive fibrosing ILDs. Now, progressive PF ILDs, as I would call it, would be also seen in patients with hypersensitivity pneumonitis, other forms of ILDs, autoimmune diseases, exposure-related ILDs, and some forms of sarcoidosis. But what we know and what we do not know about these ILDs are reasonably clear now. One is they have common pathogenetic mechanisms. They have self-sustaining fibrosis, they have declining lung function, they are worsening dyspnea, their deterioration in the quality of life is significant, and they have a reasonably early mortality. But what we do not know is what are the markers or predictors of disease progression. We do not know the role of immunosuppression or antifibrotic therapy, nor do we know how to assess treatment response and validated patient-reported outcomes. The role of imaging is very important in assessing fibrosing ILDs. You see, this is a classic case of a UIP pattern, which has progressed to advanced stage of end-stage lung disease. Here again, you see another patient of a non-specific interstitial pneumonia who finally progresses to end-stage ILD with the asymmetrical UIP-like pattern. So the imaging techniques are becoming important, and the HRCT is becoming the cornerstone for diagnosing ILDs, allowing for initial differentiation between the UIP and other ILDs. Imaging outcomes must be considered alongside the results of other diagnostic procedures. Semi-quantitative and quantitative measures of fibrosis also correspond with the physiological outcomes. And what is very interestingly coming is quantitative image analysis and the use of machine learning and artificial intelligence in identifying and quantifying fibrosis in these patients. We have by now known that the natural history of fibrosing ILDs, and it is quite clear that the patients who start off with a worse lung function, worse FVC, progress rapidly, and those who start off with DLCs less than 50% have a worse and a rapid disease progression. So the decline in PFTs is an important marker of worsening lung functions. The HRCT patterns, the physical function, the quality of life, symptoms, number of acute exacerbations all contribute to the worsening of idiopathic pulmonary fibrosis and the PF-ILD forms. In idiopathic interstitial pneumonia, we have long known that the diagnosis is the prognosis. And this is a slide which I took out of my very old presentation of mine. And you see, when you have an idiopathic interstitial pneumonia pattern of a fibrosing ILD, this is the Kaplan curves for this, and the survival in the idiopathic interstitial pneumonia of the fibrosing variety have a worse prognosis, worse survival compared to those with the collagen vascular disease associated interstitial pneumonias. And how do you prognosticate this? You have physiological scores like the GAP scores, which includes the gender, age, and physiology, which does not take the HRCT findings into consideration. And you can have a reasonable prognostication of these patients. Here I have a 71-year-old lady with progressive shortness of breath, dry distressing cough, distress treatment for tuberculosis long time back. CTD none, CTD markers all negative, no environmental occupational exposure, with a FPC less than 50% of predicted and a DLC less than 50% of predicted. And these are the CT findings. She had a GAP score of 7 with an approximate 1-year mortality of 40%. This lady died at 1.5 years after we saw her initially. So the GAP score can give us a reasonable idea about the mortality and the prognosis. So the level of dyspnea at the baseline, DLCO less than 40-50% of predicted, DSATs during a 6-minute walk test, extensive honeycombing, pulmonary hypertension are poor prognostic markers. Increasing level of dyspnea, these are dynamic things. Increasing level of dyspnea, worsening lung function, worsening DLCO, and worsening fibrosis also are poor prognostic markers. So far as treatment is concerned, again, we have moved a long way from this Panther IPF trial, which lumped prednisolone azathioprine and NAC out of the window. This was the trial on NAC, which was again proven not to be of any benefit in patients. And finally, there was some hope, which was published in the capacity trials, and they showed that pirfenidone had a favorable risk-benefit profile and presents an appropriate treatment option for patients with idiopathic pulmonary fibrosis. This was the ASCEND trial, which also showed that pirfenidone, as compared with placebo, reduced disease progression as reflected by lung function, exercise tolerance, progression-free survival in patients with IPF. Treatment was associated with an acceptable side effect profile and fewer deaths. Then came nintedanib. Nintedanib was an intracellular tyrosine kinase inhibitor, which has shown antifibrotic, anti-inflammatory, and vascular remodeling effects in various non-clinical models of fibrosis. And the Impulses 1 and 2 trials in patients with IPF and nintedanib showed a reduction in DFPC, which is consistent with the slowing of disease progression. However, nintedanib had a side effect profile in the form of diarrhea, which led to discontinuation of the study in about 5% of patients. This was the findings of the Tomorrow trial, which was an open-label trial, and nintedanib was also assessed in the inbuilt trial in progressing fibrosing ILDs, and it showed that it reduced the rate of LVC decline in progressing fibrosing ILDs. But what is the rationale for evaluating antifibrotic therapy? Antifibrotic therapy is approved for use in IPF only, but IPF is a prototype of progressing fibrosis, and similarities in the biology and clinical data and animal models support the evaluation of antifibrotic therapies in ILDs, fibrosing ILDs, other than IPF. There is insufficient data about the use of nintedanib in other diseases, but at the same time, immunosuppressives do not work. It does not reverse fibrosis, it may itself cause interstitial changes, and are associated with an increased risk of other adverse events. Hence, the evaluation of drugs like nintedanib has come in. We must address comorbidities, especially GERD. We must address cardiovascular comorbidities. We must address pulmonary hypertension, but unfortunately, none of the trials, large trials in pulmonary arterial hypertension, has shown any benefit. All of them were negative trials. So it is pointless to try and target treating pulmonary hypertension associated with fibrosing ILDs, but it remains the fact that if a patient develops pulmonary arterial hypertension, the prognosis is definitely poor. Adverse complications like cardiovascular disease, venous thromboembolism, and lung cancers. I have not included one thing in my study, that is the management of acute exacerbations of IPF or idiopathic pneumonias, which is a topic in itself. But before I wind up, it is very important to mention one thing, that we must have more interdisciplinary and multidisciplinary team meetings for diagnosing ILDs, because we need to have consensus diagnosis. We need to understand clinical behavior more clearly, optimize investigation, and manage recommendations. Multidisciplinary team meetings are good for identification of pattern, because pattern identification is a practice. Not all patterns are typical. Treatment decisions are difficult at times. We must decide follow-up patterns. We must form patient clubs. Home and family support must be counseled, and end-of-life care issues are usually addressed to the multidisciplinary team meetings. It is a friendly battleground, but I think this is a necessary battleground to hone our skills into punching the bag at the right place. And when you come to treating ILDs, it is much like playing a game of patience. You have, as I see it, or as we see it from our ILD clinic, we have 4 treatment groups: pirfenidone, nintedanib, steroids with immunosuppressants, and immunosuppressants only. Now, you fit your diagnosis into each of these criteria. UIP IPF would be treated with pirfenidone, nintedanib. Sarcoid cop group HP would be treated with steroids. Steroids and immunosuppressants would be probably the cornerstone in NSIP CDD-ILD, and immunosuppressants only may be an option in CDD-ILD. However, you might need to change your card sometimes because any of these diseases may move from the steroids group to the steroid immunosuppressant group, or from the immunosuppressant steroid group to the immunosuppressive only group. But the new kid on the block is a progressive fibrosing ILDs. No clear definitions of immunosuppression only or steroids only or porphyrinone and betaine only. We do not have very clear ideas. We do not have any clear ideas, but follow-up would remain very, very important in these patients. Thank you.
Technical team.
Dinesh?
Okay. So, what is this? So, hello, technical team. Can I have full screen? It's there.
I think the technical team is muted, so they can't hear.
Sir, continue. You are a full screen.
I am in full screen. Please give me regular.
Yes, sir. Continue.
I agree. Please give me regular feedback. Am I audible?
Yes, sir. You are audible.
Okay, Ongsu,
Yes,
that was exhaustive and excellent, but I have a very poor voice today. So you have to be extra careful to listen to me. Now, so you have covered well the part of idiopathic pulmonary fibrosis and progressive fibrosing ILD. And I think in our audience, there may be some more people who have joined late. So again, we'll give a nutshell. How do we come across DPLD? Primarily, the symptom is related to the anatomical extent. That means more the lung dries up, more shortness of breath is there. So symptom first. Clinical examination, there is a clue. If there is anything extrathoracic, it is unlikely to be IPF. IPF is restricted to the thoracic manifestations only. Then we go for radiology. Don't forget your old friend chest X-ray, and particularly search for previous chest X-rays. And in the same tune, at present, you can search for previous CT scans also. Same thing, PFT gives you a good guide on monitoring, and we make it a point to quote for 6-minute walk test as well, provided it is not case of acute interstitial pneumonia. And after diagnosing IPF now also, so what is the difference exactly clinical wise from idiopathic pulmonary fibrosis to progressive fibrosing ILD? Is it just the tempo of the disease process clinically?
it is probably the tempo of the disease process which is different. And in our experience, I think we have a false sense of security that whatever treatment or monitoring we are doing to the patient, they are living longer. But they are living longer just by the fact, just because of the fact that the disease behaves in a different trajectory. But it goes without saying that we now are seeing many more progressing fibrosing ILDs who are living for 7 to 10 years. And finally, all of them land up in that final common pathway of extensive fibrosis, which mimics advanced UIP.
Okay, we'll discuss it at the end in the interaction. Actually, it is the radiologist's interpretation. David Lynn first started it, that in HP, the prognosis does not depend on acute, subacute, and chronic. Rather, the presence of honeycombing in the CT scan, basal honeycombing, that determines the prognosis. So, also, is it possible that retrospect, many of the progressive fibrosing ILDs have been erroneously diagnosed as idiopathic pulmonary fibrosis?
Quite possibly, because if you look back, say 10 years from now, the understanding of HRCT scan and differentiation between UIP and other forms of ILD was not very clear. So many of these patients may have been wrongly labeled as being IPA. That is number one. And the number two is uh, our understanding of these ILDs have changed over the last 8-10 years. Now we are in a more we are having the advantage of better quality scans, and we are having the advantage of better quality biopsies, and we are having the advantage of following up these patients more rigidly or more organized in a much more organized fashion. So that gives us an insight as to what the patient's clinical behavior has been. But I strongly believe that many of these patients may have been wrongly classified as IPF.
Because also all of us has noticed some of the IPFs lived very long, so-called
Yes,
IPFs.
exactly.
We
Those with
diagnosed
slow
in
progression.
2012, they're coming still in 2019. So probably many of them were not really IPF. They were progressive fibrosing ILD. Okay, thanks Omsu, but stay there. We'll be coming to the introduction at the end. Now I invite Dr. Devabani Vissas from Sagat Datta Medical College. There is a big chunk there, again clinically very interesting and confusing as well. The group of hypersensitive pneumonitis and the so-called CTD-ILD, and needs no saying ILD with autoimmune features. So Dr. Devani Vissas, please, technical team.
Good evening. In this session, we are going to discuss chronic hypersensitivity pneumonitis and connective tissue disease associated ILD. The first ever description in history of hypersensitivity pneumonitis was given by Ramazini in 1700. Almost more than 100 years after that, it was Dr. John Finson of Iceland who described the similar disease condition among a group of workers in a barn who used to handle hay with their hand before feeding their cattle. He termed it as hay carter disease, and now it is known as farmer's lung. Another 100 years have passed, but still now we do not have any widely accepted definition. There is huge knowledge gap on the pathogenesis, and truly speaking, it is very difficult to elicit history of inciting agent. We are lacking clinical practice guideline, and so diagnosis and management of HP varies widely from region to region. There is also paucity of therapeutic clinical trials in this field. This is a milestone publication by Dr. Morrell and his colleagues, who highlighted that there is diagnostic overlap between IPF and fibrotic HP. He described a sizable proportion of patients who were initially diagnosed with IPF according to 2011 ATS guideline, but later on their diagnosis was revised and they got a diagnosis of HP. So that initiated us to rethink our concept of HP. And here came the first ever official clinical practice guideline on diagnosis of hypersensitivity pneumonitis in adults in August 2020. So HP is now defined as inflammatory and/or fibrotic disease affecting both lung parenchyma and small airways. It typically results from an immune-mediated reaction provoked by an overt or occult inhaled antigen in susceptible individuals. It was grossly underreported only in few case studies and small studies and case series until this eye-opening publication in 2017. This was publication from Indian Registry of ILD, where more than 1,000 patients from different corners of the country, their diagnoses were reviewed by ILD experts at a different level, at local level, then at national level, and also at international level. And then they came up with the finding that it was HP which constituted almost 50% of the total ILD population. Now, the clinical phenotypes, it is no more classified according to its acuteness of onset, but now its behavioral pattern is given importance. So it is classified as whether fibrotic HP or non-fibrotic HP. They have given a huge list of probable inciting agents constituting both organic and inorganic particulate matter. Now coming to diagnosis, the primary goal in diagnosis of ILD is to make a confident diagnosis using the least invasive approach. We know that the finding or demonstration of typical HP pattern can give us a definite diagnosis. However, it is no more mandatory. Rather, HP could be diagnosed with pretty high confidence with typical findings of HP in HSCT along with demonstration of bile fluid lymphocytosis even without any histological sampling. So, MDT to be done, that is multidisciplinary discussion to be done before we can make a diagnosis of hypersensitivity pneumonitis. So these are the HSCT pattern of non-fibrotic HP. By typical HP, it means that the pattern is highly suggestive of diagnosis of HP, and it requires at least one HSCT abnormality indicative of parenchymal involvement infiltration in the form of ground glass opacity or mosaic attenuation, and at least one HSCT abnormality indicative of small airway disease in the form of centrilobular nodules or airway trapping in expiratory film, with or without basal sparing. Now, by the term compatible with HP, it means that though less frequent, these patterns are less frequently reported, but it is still compatible with HP. Now, HSCT pattern of fibrotic HP, their demonstration of lung fibrosis is essential and it is demonstrated in the form of fine or coarse reticulation, septal thickening, then traction bronchiectasis, honeycombing, though less predominant, in the background of GGOs. Now this is 3-density pattern where we can find areas of 3 different densities, normal lung densities, then hyperattenuated areas, which are basically GGOs, and then low attenuated areas, which are trapped air. And this 3-density pattern was previously described as head cheese sign. And this is very specific for fibrotic HP. It can differentiate this condition from a very similar condition called IPF with very high specificity and moderate sensitivity. Upper lobe predominance is very common in fibrotic HP. It is very specific of HP, though it is present only in less than 10% of the population. Now coming to histopathology, demonstration of cellular interstitial pneumonia, which is bronchiolocentric, along with poorly formed non-necrotizing granuloma, while in absence of features suggestive of alternative diagnosis is described as a typical finding of HP. Here, lymphoid aggregates generally lack secondary germinal center. We have to remember that the presence of follicular lymphoid hyperplasia and plasma cell predominant infiltrates that favors alternative diagnosis. Now, typically, the granulomas of HP are small and poorly formed, comprising of loose, poorly circumscribed clusters of epithelioid and multinucleated cells. In peribronchial interstitium, isolated multinucleated giant cells are common and often show non-specific cytoplasmic inclusion bodies. The presence of subpleural and centroacinar fibrotic lesion with or without bridging fibrosis is very important in differentiating this fibrotic HP from other fibrotic IIPs. Now coming to the role of bronchoscopy. Here the guideline committee the guideline committee, they have decided that they have given a threshold of lymphocyte count about 30% to be quite reasonable. They have recommended, in case of non-fibrotic HP, the guideline committee has recommended that bile fluid lymphocyte cellular analysis would pretty well differentiate this condition from other conditions with other similar condition with high lymphocyte count in bile fluid like sarcoidosis and IPF. Not only that, it should be done in order to rule out other infective etiologies. However, for patients with newly identified ILD, whose differential diagnosis includes fibrotic HP, guideline committee has suggested bile fluid analysis only. Now, questions unanswered till date is in management of HP is there is lack of any validated questionnaire to determine history of exposure. There is lack of an internationally accepted HP panel to be tested. The role of bile fluid lymphocyte count in distinguishing fibrosing HP from other progressive fibrosing ILDs are yet to be determined. And large randomized controlled trials are needed. Now coming to connective tissue disease associated ILD. CTD is a spectrum of autoimmune disease disorders with significant clinical heterogeneity causing immune-mediated organ damage, and lung is a frequent target. Though prevalence of lung involvement is varied among different subgroups, all CTD patients are at risk of ILD at some point of its natural course. So comparatively, systemic sclerosis related ILDs have been studied widely. It has been explored in more details, and long and large randomized trial has been conducted on it. And so in the later part of my lecture, I'll be more concerned focusing on this group of patients. The patient may visit chamber of rheumatologist or a pulmonologist. Because rheumatologists, they need to be more careful about screening for ILD in an early stage so that some intervention can be done. In case of pulmonologist chamber, patient may present with shortness of breath, dry cough, HSCT thorax may be showing patterns suggestive of ILD. So in that case, we have to search for probable etiology behind this newly diagnosed ILD. And also we have to little bit careful about extra pulmonary manifestations of related to these connective tissue diseases. Now coming to rheumatoid arthritis associated ILD, about 10% of this RA population, they develop ILD with median survival of only 3 to 7 years. As I have said, RA-ILD can occur at any point in natural history of RA. Even ILD may present before appearance of joint involvement. So early diagnosis is definitely a challenge. HSCT thorax shows high correlation with histologic pattern, which has almost replaced lung biopsy. UIP pattern is most common type. Other patterns can be seen are non-specific interstitial pneumonia, organizing pneumonia, desquamative interstitial pneumonia, lymphocytic interstitial pneumonia, and mixed pattern. MDD is the best approach to diagnose RA-ILD involving rheumatologist, radiologist, and pulmonologist. So who are at risk of developing interstitial lung disease? Male gender, elderly population, smoking history, those with shorter duration since diagnosis, that is early in the phase of diagnosis, early in the course of disease, those with high titer of anti-CCP and rheumatoid factor, those with baseline low level of DLCO, those with extensive lung involvement on HSCT, rather than UIP pattern, they are at increased risk. There are certain investigational biomarkers identified, like MMP7, PERK, and SPD. Identifying rheumatoid arthritis in interstitial lung disease, we need to be careful in differentiating this condition from other CTD-related ILDs and IPF. UIP pattern is more common in RAILD patients, while NSIP pattern is more common in other CTD ILDs. These are the poor prognostic factors, that is advanced age at diagnosis, more than 60 years, high titer of anti-CCP, low baseline level of DLCO, definite UIP pattern, and high fibrosis score, and extent of traction bronchiectasis on HSCT. One thing I must mention over here is that there is no evidence there is no influence of glucocorticoid or conventional DMRDs on progression of disease has been established. So still date, there is optimal therapeutic regimen of rheumatoid arthritis has not yet been determined due to lack of randomized control trial. Now coming to scleroderma. Scleroderma is a heterogeneous autoimmune disease characterized by immune dysregulation, microvascular damage, vasculopathy, fibroblast proliferation, which leads to extracellular matrix deposition and organ fibrosis. The same thing occurs in case of lung. Patient may present with limited cutaneous scleroderma, features of, or may present with features of diffuse cutaneous scleroderma. HSCT pattern shows fibrotic NSIP pattern is more common than UIP pattern. PFT shows restrictive pattern, and biomarkers anti-SCL70, anti-topoisomerase 1 with or without anti-centromere antibody. The scleroderma patients, they have got very variable clinical course. Some may remain stable for a pretty long time, while others may deteriorate very sharply, or others may deteriorate slowly. This is a very interesting slide which shows the changing pattern of cause of death in systemic sclerosis over last 3 decades. It shows that it is pulmonary complications, be it pulmonary fibrosis or pulmonary arterial hypertension, which is the major cause of death in modern days, rather than renal crisis. So who are the patients at risk of developing ILD in this scleroderma patients? It is greatest early in the course of disease. So PFT need to be done every 4 to 6 months for first 3 years. Presence of diffuse cutaneous scleroderma. Though systemic sclerosis is more common, more prevalent among female gender, male population are at risk of developing ILD. There are certain ethnic population who are at increased risk, older age at diagnosis on disease onset, and presence of anti-SCL70, anti-topoisomerase 1. These are the people who are at risk of developing ILD. Now, once ILD has developed, who are at risk of progression? Again, those with diffuse cutaneous sclerosis, certain ethnic population, those with advanced stage at diagnosis, those with low baseline pulmonary function and low baseline DLCO, and extent of disease on HSCT is also a very important factor. Different biomarkers have been investigated, and their prognostic value has been investigated, but none has been, but all of them are still at investigation level. Many patients with idiopathic interstitial pneumonia have clinical features suggestive of underlying autoimmune process, but they do not fit into an established criteria for connective tissue disease. In 2015, ERS HES Task Force on Undifferentiated CTD-associated ILD, they proposed the so-called research concept of IPAF, that is interstitial pneumonia with autoimmune features. They suggested diagnostic criteria where at least one feature, they suggested three different domains: clinical domain, then serological domain, and morphological domain. And they suggested that at least one feature from at least two of these domains need to be present in order to diagnose a case to be IPAF. And definitely after excluding other alternative etiologies. So management goal of all these conditions, the first and foremost is ameliorating the disease, slowing down disease progression while improving or maintaining quality of life, educating patients, and shared decision making to be encouraged. Now, since SSC-ILD has been widely studied, clinical trials have been conducted on this group of patients. My focus will be on these patients, this group of patients. Here I would like to emphasize, I have just highlighted few very important trials. The scleroderma lung study 1, they have established role of cyclophosphamide against placebo in management of this group of patients. They have caused significant improvement in FVC and total lung capacity at the end of 12 months. In scleroderma lung study 2, MMF had been tried versus cyclophosphamide. At the end of 24 months, MMF have came up as a better alternative, better tolerated drug, though better efficacy has not been proved, confirmed. Other immunomodulators like rituximab and tocilizumab and other, they have been tried and trials are going on. Some of their results have been published and others are still pending. Then came the new era of antifibrotics. So studies has been conducted with pirfenidone and nintedanib both. There is Lotus trial where pirfenidone titration has been tried and whether it is this group of patients are benefited by this antifibrotic has been tried. And it was found that longer titration was better tolerated. That is 4-week titration was better tolerated in this group of patients. In SLS scleroderma lung study 3, pirfenidone with MMF have been tried in one arm and it has been compared with MMF with placebo. Results are yet to come. In census trial, nintedanib has been tried against placebo, and it has been shown that nintedanib is effective in reducing FVC decline, though no clinical benefit in other organ damage has been demonstrated. Now, decision to start treatment in RA-ILD, as I have said, multidisciplinary evaluation need to be done before decision can be taken, and that included demographic profile of the patient, like age, gender, comorbidities, his symptoms, histopathology or HSCT pattern, his functional lung capacity, then quality of life, then his articular, then the activity and severity of joint diseases and other extra-articular manifestations. So our armaments with us are different disease-modifying anti-rheumatoid drugs, then immunosuppressants and antifibrotics in these days. So we have, before considering the drugs, we have to consider whether the patient has articular non-active disease or articular active disease, whether it is UIP or non-UIP, or whether it is a progressive ILD or non-progressive ILD. But before treating these patients, we have to keep in mind that treating ILD in a patient of rheumatoid arthritis who is already receiving some sort of DMRD disease-modifying agent is not the same as treating rheumatoid arthritis in a patient with concomitant ILD. The therapeutic approach to RA-ILD is still debated, so which medicine to choose over the other. So these are few trials on RA-ILD. Results are yet to come. Several antifibrotics has been tried on chronic HP. This inbuilt trial, nintedanib, has been tried, and this relief trial, pirfenidone, has been tried, and it has been showed that both of them showed quite good efficacy in reducing decline of FVC in this condition. This is almost a summary slide where we can see that in SSC-ILD, glucocorticoid is no more a drug of first choice. We will be considering immunomodulation treatment. Here MMF, that is mycophenolate mofetil or cyclophosphamide, tocilizumab, azathioprine, rituximab may be considered. In case of RA-ILD, however, glucocorticoid is a drug of first choice. Then we can add as a steroid-sparing agent rituximab, abatacept, or MMF. In case of hypersensitivity pneumonitis, removing the patient from further antigen exposure should be tried, and then glucocorticoids along with MMF with or without azathioprine may be tried. Antifibrotic drugs like nintedanib is definitely a choice in all of them in advanced cases, in selected cases. Non-pharmacological treatment should be practiced, including supplemental oxygen, psychological support, smoking cessation, rehabilitation, symptom palliation, and end-of-life care. Leflunomide has been tried in some trials in case of chronic hypersensitivity pneumonitis. Stem cell transplantation or lung transplantation may be considered in more advanced cases. The patient should be regularly followed up to see whether symptoms have ameliorated or disease condition is stable or disease has progressed further. In that case, we have to monitor the disease course and reconsider our management. So thank you.
Am I audible, technical team?
Yes, sir, you are audible.
Am I visible?
Not yet.
Make it visible. Am I?
First, start your camera.
Okay. I will do. Just wait. Because you are not doing with me as I said. Okay. Am I audible?
Yes, sir, you are audible and visible.
So, Devani, that was good. Now I start with the last part. So you have written that stem cell transplant or say lungs transplant. Ongsu, are you there? Ongsuman?
Yes, I'm here, sir.
Yes. So Ongsuman, in which cases of ILD that you get, you discuss the potentiality of lung transplant? transplantation?
Frankly speaking, lung transplantation should be thought of much before the patient is landing up in a situation of end-stage lung disease with supports, in a crisis situation where he cannot be transported to the transplant center. That is one very important thing. And one important takeoff from the multidisciplinary team meetings is we try and select patients who will be feasible for a lung transplant. So first of all, younger patients with progressive fibrosing ILDs with no clinical comorbidities are the ones in whom we should start thinking of doing lung transplant. So when we can
Okay,
document.
Inshu, I take it. Devani, yours is a government hospital, lot of patients. Any chance of discussing lung transplantation potentiality with the patient of ILD? Devani, is he here?
Yes, she is.
Hello, am I audible? Okay, so let Devani come. Actually, lung transplantation should be discussed in all patients with ILD. The patient at least should know that it is there, it is feasible, not in many cases, but it is. So practically, particularly when you're talking of IPF or progressive fibrosing ILD, definitely one should discuss about lung transplantation. So that is to be highlighted, number one. Number two, about this multidisciplinary team. So it is very needed. Ongsuman again, is Devavani there? I don't get her. Okay. So Ongsuman,
Yes.
what is your level of confidence when you diagnose a case of IPF on your own versus a case of hypersensitivity pneumonitis on your own? Level of confidence.
So we have been doing a MDT meeting over the last, say, 5 years, almost close to 5 years now. So what we do is we have seen that we have, for the diagnosis of confirmed UIP pattern,
Louder, Ongsu, louder.
the diagnosis of a IPF from a confirmed UIP pattern, we are very confident. We can say that this is a diagnosis of IPF. But when it comes to patterns, CT patterns, which do not fit into the typical UIP pattern, is a possible UIP pattern.
That part taken, Ongsu. Now come to HP. Do you ever get that level of confidence in diagnosing HP?
HP, the differential diagnosis of HP is, with other forms of ILDs, idiopathic pulmonary, idiopathic interstitial pneumonias of the fibrosing variety, and HP are sometimes very difficult to differentiate. And we are not doing a lot of transbronchial lung biopsies or lung biopsies on these patients. So I think a confident diagnosis of HP always is not possible.
Actually, so. So practically HP is a very difficult diagnosis, particularly you can never prove. So HP, number one, the CT pattern. The CT pattern will be first the gradient. It is present vertically more at the top rather than at the bottom, but the gradient is there. And then the mosaic pattern indicative of air trapping. So you get a characteristic CT, then you get the positive exposure history or the precipitating antibodies and bulk lymphocytosis. But above all, it ultimately needs a confident clinical diagnosis. HP is probably more difficult confidence level wise than to diagnose IPF when you get the typical CT pattern of UIP in again a male patient aged 50, more the age, more the chance better. So aged 60, say 60-year male UIP pattern, you are much more confident in diagnose IPF compared to HP. Now,
Also,
yes,
I would like to say one thing. Apart from the radiological patterns only, when from the history we try and glean out a history of exposure, most often we do not get any history of exposure in our country.
We don't. Yes.
We don't. So that is one thing. And the other thing is bile fluid lymphocytosis. The quality of bile fluid examination and the processing of the bile fluid is something which we are still looking at optimizing in our laboratory also. So I think bile fluid lymphocytosis, I'm not very confident about what we get from the lab.
And also, Devani has suggested there is no consensus on what is the HP panel we should look for. There are HP panels done, but we don't really know which one is really. And moreover, presence of antibodies does not make it a case of HP. So that part is also there. Again, yes, sarcoidosis versus hypersensitivity pneumonitis. Also, your take sarcoidosis. Don't forget this hilar lymphadenopathy business. The diffuse parenchymal sarcoidosis versus HP.
There is a lot more transbronchial biopsies and endobronchial biopsies which are done in sarcoidosis. So, if leaving apart the CT pattern, I think sarcoidosis diagnosis is reasonably more confident than a diagnosis.
Definitely, yes.
Diagnosis of HP. And physiologically also, I think the patients of chronic HP and the patients of sarcoidosis, we get a better set of patients in sarcoidosis so far as the lung physiology is concerned. So many of them finally get a lung biopsy, a transbronchial biopsy, or an endobronchial biopsy, which can help us in giving the diagnosis. We do not have so many biopsies in patients suspected of being chronic.
There was a controversy here that in ILD India registry, which we are a part of, and particularly from the North Indian representatives, so many cases of HP, and PGI Chandigarh suspected that many cases of sarcoidosis have been classified as HP in that group. Actually, they even wrote a letter to this.
Actually, there are diagnostic bias also. Every MD multidisciplinary team has a bias. So I think some of the biases have crept into these.
Okay, but MDT is primarily there to take off the bias, isn't it?
Yes, I understand, but institutional biases are always there.
Okay.
So I think it does creep in. There's nothing wrong in it. It does creep in.
Now I come to this rheumatological diseases. There are interesting studies that show pulmonologists not necessarily get the opinion of rheumatologists in cases of ILD. And similarly, rheumatologists, when they say case of rheumatoid or PSS, usually they don't take the opinion of pulmonologists. So there is a lot of gap still now between the two specialties. In the ILD India registry, we had rheumatologists in our club, as also other specialties, to have a good consensus. And rheumatologists claimed that all cases of ILD should get a baseline serum investigations for ILD rheumatology markers. He claimed all cases of ILD should have a panel of serum rheumatological markers. Your take, Ungshu, on this? Ungshu, can you hear me?
Yes, I didn't get your question, sir. There is a problem with my microphone. I didn't get your question clearly.
Okay, I am repeating.
Yes.
Rheumatologists in our ILD India registry claimed that usually the rheumatological diseases are underdiagnosed. So to compensate, he suggested all cases presenting as ILD to the pulmonologist should have a battery of serum markers for rheumatological diseases, a basic battery. Say serum rheumatoid factor, anti-CCP, ANA, and maybe SSCE. Your take on this?
Yes, I agree with that, absolutely. So all patients with ILD should have these basic tests. RA, ANF, SSCE should be there in all patients.
Okay.
Even without the absence, even with the absence of typical joint symptoms.
Yes. that is true. Practically, the rheumatological part is frequently underdiagnosed, and the other way also. The patient going to rheumatologist with, say, particularly rheumatoid arthritis, don't have the lung diagnostic makeup, whether he has ILD and whether it is the nature of this, they don't. So probably there is a gap that we must bridge.
And also Devavani has highlighted one very important thing. The patient of RA-ILD is different from a patient of ILD with rheumatoid arthritis.
Exactly. Same thing there. So also, okay, coming to this question from this. So in a patient of ILD with CTD markers quite convincing, say in a case of rheumatoid, do you need to go for lung biopsy in any case, or you don't?
We don't. Because we don't. We are not going to achieve anything extra by doing the lung biopsy.
Actually, in PSS, this does not arise. However little it is, PSS is essentially a clinical diagnosis. And then you have to go for the markers. But we don't diagnose PSS by presence of anti-SCL70. We don't. We do it clinically first. Exactly. So PSS basically remains a clinical diagnosis with a high index of suspicion. I am showing here, this was David Lynch, a brilliant researcher and orator. I have heard him several times, and we are discussing in some of this. CT phenotypes in hypersensitive pneumonitis, actually that is the start of this progressive fibrosing concept, where he says the classification of HP based on the presence and pattern of fibrosis may be more helpful than the traditional classification of acute, subacute, or chronic. And also you have showed this, the progressive fibrosing ILDs, and it can be anything, apart even from IPF.
Exactly.
So, okay, we agree. It can be CTD-ILD, it can be HP, and I think a lot of HP are there. Just a word about NSIP also. We don't discuss NSIP that much, because NSIP is essentially a conglomeration. It can be anything. Even say PSS, you can get NSIP picture. But apart from these secondary NSIPs, non-specific interstitial pneumonia, do you believe that there is an entity of idiopathic NSIP? Yes or no?
Yes, absolutely. I believe there's an entity of idiopathic NSIP. But when we look at the newer classification of UIP, that has been the HRCT classification of fibrotic lung diseases that has been given in 2018, you will find most of the NSIPs hidden in that indeterminate group. Indeterminate for UIP group. So, patients without a basal predominance, but reticulation is present without any classical features of honeycombing, and a lot of ground glass, I think, are the ones where we should start looking for NSIP. And clinical behavior patterns, especially with response to steroids in these patients, I think is one of the determinants of whether this patient is NSIP or other forms of IP.
So practically, idiopathic NSIP has to be a diagnosis of exclusion actually.
Yes, I think it is a diagnosis of exclusion.
Because in many NSIPs, if you look carefully, ultimately you get some type of CTD-ILD, maybe even ILD with autoimmune features. Maybe only the serum markers positive, still no clinical manifestations. So NSIP, yes?
One thing we have also seen in our early clinic, many patients in whom we classified them as NSIP, later the pattern of NSIP predated the rheumatoid factor positive.
Yes, that's what I was going to.
So NSIP pattern can predate clinical features of frank rheumatoid arthritis. So I do not know whether we should call it a ILD associated with rheumatoid arthritis or a RA-ILD. I really do not know how to put this.
These are RA-ILD, maybe predate. These are RA-ILD actually. Again, we are ready to accept any questions or comments from the audience. So anybody there may put it in the chat box, or hello technical team. Are you receiving any questions? You have to send it to me. Technical team, are you there?
Yes,
hello?
sir. Yes, sir. We are just getting questions. I'll post it in the chat box.
Don't delay. Practically, we are not waiting for the whole night. I think you should have started it by this time. I have not got anything, but whenever you get it, you send it immediately. Okay? And then, so to summarize what we have discussed today, this is Nobi Pulmonology Masterclass. Topics are chosen according to their clinical context, their fundamental understanding, and areas of controversy or confusion. We have discussed that DPLD very initially in the 60s was an anatomical diagnosis. In the 70s, we understood DPLD is not diagnosis, it is just anatomy. We have to proceed from there. Then CT came in the 80s. We got the spectrum. And then we understood, because IPF is a disease with serious morbidity and mortality, this has to wait the maximum. Devani, I see you there now. Are you there, Devani? Devani, can you hear me? I think.
You are not audible, madam.
Yes, sir. Audible, sir.
No, I am audible. Devani is not audible.
Okay.
Maybe. Anyway, so we have discussed that. Then whole purpose was to differentiate IPF from the non. Whole purpose was primarily to dissociate the idiopathic interstitial pneumonias from the other group. And from other group means the known, so-called known. We have discussed. One was the rheumatological vasculitis, the common association group. One was the histopathologic presentation of granuloma, the sarcoidosis Chuksta's group. One was just a clump of small prints in DPLD, say LAM, lymphocytic interstitial pneumonia. When you took them out, what remained is a big chunk of idiopathic interstitial pneumonia. In idiopathic interstitial pneumonia, the very big one is idiopathic pulmonary fibrosis. It take out all others. Still one mimic remains, one mimic. This mimic is non-specific interstitial pneumonia. Very much difference in prognosis and response to therapy. So we tried everything, and ultimately now the radiology is still the king. The diagnosis is done by HRCT chest, but not only. This is a clinico-radiological pathological diagnosis. So DPLD or ILD or IPF or whatever HP you talk of, it's a clinical, radiological, histopathological diagnosis. Ongsu, your take on this comment?
Absolutely, it's a clinical, radiological, and histopathological diagnosis. I fully agree with that. But in many instances, as we have seen it, having run this multidisciplinary team for the last 5 years, it is very difficult to convince patients to get a lung biopsy in this part of the country, at least. It is extremely
not only here, Ongsu, it is global. It's a global problem. Practically, that's why they have changed the diagnostic criteria of HP.
Exactly.
Because previously it was that you have to get a biopsy done for diagnosing HP. Now they have changed the criteria because biopsy is not liked all over the globe. Okay. And then, Devani, any comment on this? Clinical.
I have said that even if we don't get a history of exposure, then also we can diagnose HP with quite high confidence, that I have said. By high confidence, it is said that it's almost 80 to 90% confidence we can diagnose it.
Without biopsy?
Even without biopsy, just if we can ensure that bile fluid lymphocyte count can be done correctly.
Okay, that's the trend actually. But again, it is because that biopsy is not liked by anyone. That is the thing. Practically, the history of exposure may be very tricky. We all know. Very, very tricky. And
more than 60%, it says that we don't get a history also.
And the presence of antibodies does not prove anything.
No.
So ultimately,
no, it doesn't.
Confident clinical diagnosis. Probably we may include some non-specific interstitial pneumonia as well. And practically, what happens in cases of, say, we get many cases like this, a HRCT pattern which is practically unclassifiable. Then we look at the esophagus in the CT. We understand the esophagus is dilated. So only on this, we suspect a case of PSS. We go back clinically because we have seen the CT only. Now we confirm this is a case of progressive systemic sclerosis. So practically, unless you correlate the clinical part with the radiological part and then probably the histological part. So we have got all this. We have got some questions. Let me see. One is, yes, this is Devani. Is there any role of bulk CD4-CD8 ratio in diagnosis of HP? You have got bulk lymphocytosis, more than 30%, yes, I agree. Is there any role of CD4 versus CD8? Both Devani and Ongsu. Devani first.
No, actually, it has not been studied there. It said that CD4 count is altered in case of sarcoidosis, because sarcoidosis also shows increased lymphocyte count. But it is said that HP, in case of HP, that lymphocyte count is much more than sarcoidosis. But CD4-CD8 ratio has not been studied. It has not been compared as such. Head-to-head comparison has not been done in any study yet. I didn't find anything.
Ongsu, any comment on this? Ongsuman? Is Ongsuman there? Can I hear him? Okay. There was another Devani from here. So this ILD with autoimmune features, is it separate from CDD-ILD?
Actually, I think it's a waste paper basket. When everything is not matching CTD diagnosis, then we are grouping it together so that this diagnosis is basically for research purpose, I think, so that we can identify this subgroup of patients, and we can continue. We can study this group of patients better.
Okay, I take it. Before Ongsu says, okay, I take no. The thing is, let us be transparent. In even classification of connective tissue diseases, there is a group known as unclassifiable.
This is the thing, IPF.
Come on. There is a group known as indeterminate. So practically ILD with autoimmune features is actually indeterminate. What is the difference from CTD-ILD? In CTD-ILD, the CTD part is very overt. You get a patient of rheumatoid arthritis, you get a patient of PSS, even you can get a patient of Sjogren, and you get the ILD, this CTD-ILD. Here, the ILD part is there. There is no overt clinical CTD, but you get the markers positive. That means this patient, number one, has to be observed longitudinally to see that it develops the features of CTD. Number two, the treatment part. This is a patient having more favorable response to appropriate treatment compared to another ILD where there was no autoimmune features. So autoimmune means here you have chance for anti-inflammatory and immunosuppressives. Okay, Ongsu, can you hear me?
Yes, I can hear you now.
There was a question, is there any role of bulk CD4 versus CD8 in diagnosis of HP? Any comment?
Yes, bulk CD4, CD8 count definitely has a role in HP. But then again, my question is, we are faced with the problem of having a proper bulk fluid assessment, because bulk fluid processing in the laboratory is suboptimal. So that is why I do not know how far the bulk CD4, CD8 count will help us if the processing of the bulk fluid initially in the laboratory is not good. That is our main problem. So I think, yes, it is definitely helpful. Theoretically it is, but I do not know about the
Practicality. I agree with that.
Quality of sample handling.
Globally, now they are trying to be as user-friendly as possible. So bulk lymphocytosis is good enough. CD4-CD8 ratio does not add much. Again, at least not in HP, because HP again remains a difficult diagnosis compared to other things. Any other question? Let me see. Okay, we have completed almost. Now, also, So if you are told to say one sentence to represent what you think of DPLD in this mate, any one sentence you want to have your message. This is my message about DPLD.
Our understanding of DPLD has increased. Physician awareness about DPLD has improved. And we are in a better position to diagnose at least one sentinel form of progressive fibrosing ILDs, that is IPF.
Good. Devani?
So we have to be more critical in appreciating extrapulmonary signs and clinical symptoms so that we can diagnose, we can associate ILD with CTD or this thing, extrapulmonary manifestations.
Okay. So taken together, both of you have meant, I'll summarize. Number one, we have to give more time to a case of DPLD, isn't it? Practically, DPLD experts say, and they boast of it, they see one case in 1 hour. One case in 1 hour, DPLD experts claim, because they go through everything. And moreover, the history, actually the history part is frequently neglected when we get the HRCT. That is the problem. The patient comes, gives the HRCT, I put it in the box, and I immediately go for this, and without going for the nuances of the deep history taking. That is number one. So, more time. And number two, as I said, comparing previous chest x-rays, similarly, comparing previous CT. That is okay. And both are important, the patient identification and the pattern identification, the different patterns. And then after this, when you come to a diagnosis, I think all patients should be told about lung transplantation. Not that everybody is going for it, but lung transplantation as a subject must be discussed with all patients of ILD. However, the controversy is, do you need multidisciplinary team MDT in all cases of ILD? Ongsuman first.
Not really. When we can make a confident diagnosis of IPF or sarcoidosis or a rheumatoid associated ILD, I don't think we need a MDT. We need a MDT for patients in whom we have management problems, in whom we have follow-up problems, in whom we need to make therapeutic decisions. So those are the situations where we need, and patients in whom we want end-of-life care issues to be discussed, and in whom we want transplantation to be discussed.
So that is actually a compromise, because MDT cannot be afforded for every patient that multiple specialists will come and talk. So it depends on the clinician, but it has been seen also, the agreement is more among experts than compared to general practitioners seeing the same patient. Yes or no?
Absolutely. But the point is, if we take a general pulmonology clinic in any hospital in this city, so any respiratory physician would be seeing about 35-40 ILDs, I think, in a month, especially more so in the government institutions. And to bring all these patients to a dedicated MDT clinic is a big challenge. But one thing that the MDT clinic has helped us do is follow up these patients longitudinally. It is vitally important to follow up these patients longitudinally than see patients in a cross section. And that gives us more insight into disease behavior and management issues.
So this brings to another point, very important point, documentation. We are really not that good in documentation. So ILD registry should be with every pulmonologist. So longitudinal follow-up is the best way to understand ILD, more in retrospect. So we do always this, documentation and keeping the registry. So every pulmonologist should have documentation, and maybe in sketches, maybe you are a very busy person, but still the basic things. And don't forget the mobile number of the patient to track him down in coming years. Okay, we have not discussed acute interstitial pneumonia in this class. It is a different disease altogether. We have just quoted about a devastating disease. I have seen a young lady die within 4 days of diagnosis. Acute interstitial pneumonia can be the presentation of SLE as well. Lupus pneumonia can be the presentation. And there the treatment is practically pulse steroids with or without immunosuppressive, more so particularly cyclophosphamide. Also just
One
few,
thing.
yes, Devani, yes.
So when we are talking about that, getting a lung biopsy done is a great problem with our practice. Then how far practicable will it be to discuss about lung transplantation?
Because we are not doing it, others are doing it in India. The chances
Yeah,
are
lung
there.
transplantation.
Yes, yes, very much. Chennai is doing it, Coimbatore is doing it, even Hyderabad is doing it.
We have successfully sent patients to transplant and
Yes.
got them done. But the thing is, if we do not counsel the patients from significant with a significant margin of time, they are also not convinced. The arrangement of finances, the arrangement of everything.
Actually,
is
so. So not one word. You have to do it several times so that he understands the. And we have seen
Repeated hammering.
we have seen end stage ILD in young male who is now well with lung transplant. And again, we have been able to diminish the cost by repeated consultation with them in Coimbatore. So it is happening in India. Everybody should know this. So if there is nothing more, I think we have already spent nearly 2 hours. Yes. So thank you, Ungsuman.
Thank you.
That was excellent. Devani, that was really good. We have covered the topic as a whole. Again, this is not a webinar. This is Novi Pulmonology Masterclass. So we primarily dealt with the clinical importance, the concept, and the confusion or controversy. I thank the Lupin team, Iraq, Raja, Santosh, Hosses, and I see here our technical team, Prashant and Pronali Power. But before that, I must tell you the next class will be here. So the next class will be on 22nd January. You know it is always done on a Friday. And the last Friday will be busy, so it is the before. Tuberculosis that you need to know. 7:30 p.m. to 9:00 p.m. with two experts on the field, Supriya Sarkar and Subhasis Mukherjee. So I am no, so it is going there, but not. I am stop here. So thank you all for your kind hearing, and thanks everybody. We'll like to have more interactions in coming days. Thank you. Hero, Raja, anyone there?
No,
No,
sir.
sir. No, sir. Rajesh sir is actually in the flight. So thank you, sir. Thank you very much. But this is a very interactive and definitely very informative session, sir. Thank you.
Okay. So who
Thank
is
you
this
to all the
speaking,
audience
please?
for participation.
Pardon?
So thank you all the audience for participation, sir.
Oh yes, thanks everyone. Actually, they are the king. We are playing for them. So thank you, everybody. And is it Dinesh? Who is
Yes.
talking?
Yes,
Dinesh?
yes, yes.
Santosh, sir, I'm talking.
Santosh, sir. Santosh, sir.
Santosh, please give me a call. Okay, thank you, Ungsu,
Sure, sir.
Devani,
Okay,
everybody,
okay.
audience,
Welcome.
Lupin team.
Yes.
Thank you.
Welcome.
Thank you.
Thank you, sir.
Welcome.